All right, so welcome to week 10, Trauma and Dissociative Disorders. Today, these are our learning goals. So, the first learning goal would be to cover prevalence rates of trauma and stressor related disorders. We'll then go on to cover types of trauma and stressor related disorders that exist. We'll cover what is trauma, what is post traumatic stress disorder, what is reactive attachment disorder, what are the diagnostic criteria of trauma and dissociative disorders, what are some tips in assessing trauma and dissociative disorders, what are the theoretical underpinnings behind trauma and dissociative disorders, what are the best treatments. So we're going to rely not only on the PowerPoint, we're also going to rely on some videos to really supplement your learning experience in this online module, in addition to a handout that was provided to you that has all the diagnostic criteria of all of the diagnoses that will be mentioned in this talk today. All right, so what are the prevalence rates of trauma and dissociative disorders? So I wanted to bring up two different studies. The first study is the Developmental Victimization Study, which is done in 2005. And basically, they examined exposure to victimization experiences in a nationally representative sample of approximately 2,000 children and youth, ages 2 to 17. And what they found was 71% were exposed to one or more victimization incidents in the past year. 70% of victimized children experienced multiple exposures, with an average of 3 different kinds of victimization reported. The other study that I wanted to mention is called the National Stressful Events Survey, which was completed in 2011. And so in this study, they actually examined a national sample of almost 3,000 adults recruited from an online panel. So what they found was traumatic event exposure using the DSM-5 criteria was high, about 90%, and exposure to multiple traumatic event types was the norm. All right, so what types of trauma and stressor related disorders exist? So there is a long list to include reactive attachment disorder, also known as RAD, disinhibited social engagement, post-traumatic stress disorder, PTSD, acute stress disorder, adjustment disorder, other specified trauma and stressor-related disorders, unspecified trauma and stressor-related disorders, dissociative identity, dissociative amnesia, depersonalization, derealization, and other specified dissociative disorders and an unspecified dissociative disorder. For the purpose of this lecture, I'm going to spend a lot of time talking about reactive detachment and PTSD, as well as some differentials to consider when you're doing your assessment. Now, I did provide, again, an additional supplementary handout that has all the diagnostic criteria for all the other diagnoses that are mentioned on this slide. So please refer to that, and if you have any questions, feel free to send me an email. We can discuss it at the beginning of class, the next session, or give me a call. All right, so let's start by defining what actually is trauma. And so trauma is categorized into two different spaces. So we have acute traumatic events versus chronic traumatic events or situations. So an acute traumatic event really involves experiencing a serious injury to yourself or witnessing a serious injury to or the death of someone else, facing imminent threats of serious injury or death to yourself or others, or experiencing a violation of personal physical integrity. So these experiences usually cause overwhelming feelings of terror, horror, or helplessness. These events occur at a particular time and place and are usually short-lived. So some examples of acute traumatic events include school shootings, gang-related violence in the community, a terrorist attack, natural disasters, for examples like earthquakes, floods or hurricanes, serious accidents like a motorcycle crash or a car crash, the sudden or violent loss of a loved one, physical or sexual assault, for example, being shot, being beaten, or raped. Now, a chronic traumatic situation involves exposure to trauma repeatedly over long periods of time. So these experiences call forth a range of responses, including, the intense feelings of fear, loss of trust in others, decreased sense of personal safety, guilt, and shame. So some examples of chronic traumatic situations include some forms of physical abuse, long-standing sexual abuse, domestic violence, wars, and other forms of political violence. Okay, so now we're actually going to watch a video where a pediatrician actually talks about her experience in working with childhood trauma.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay. What kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them. Either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across a lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
All right, so now that we've really set the platform for the rest of the discussion today, hopefully you have a better understanding of the long-term implications of trauma, especially with childhood trauma, and their link to health outcomes. And so, this next slide is what are the effects of chronic trauma on the stress response, in which this was covered in the lecture, or in the video. But just to reiterate, so the hippocampus can atrophy because of exposure to hormones. Processing of threats becomes emotion-based. Exposure to chronic stress and hormones causes the startle response, and so there's this hypervigilance that takes place within the body, and the body acts as if it's always on alert. Okay, kind of what she had referred to as what happens when the bear comes home with your patient. And I think it's important for you guys to have seen that video so that when you do have your clients in the room with you, you have a better understanding of how these experiences that they're currently in can affect them in the long term. All right, so now we're going to go into what is PTSD. So PTSD is a disorder that develops in some people who have seen or lived through a shocking, scary, or dangerous event. It is natural to feel afraid during and after a traumatic situation. Fear triggers many split-second changes in the body to help defend against danger or to avoid it. This is called the fight or flight response, and is a healthy reaction meant to protect a person from harm. Nearly everyone will experience a range of reactions after trauma, yet most people recover from initial symptoms naturally. Those who continue to experience problems may be diagnosed with PTSD. People who have PTSD may feel stressed or frightened even when they are not in danger. All right, so now we're going to watch a video on what is PTSD, provided by the National Center for Post-Traumatic Stress Disorder.
Have you or someone you love ever been in a tornado or car accident? Experienced sexual or physical abuse?
Sorry.
Have you or someone you love ever been in a tornado or car accident? Experienced sexual or physical abuse? Served in a war zone? Most people have been through some kind of life-threatening or traumatic event, and it's common to have stress-related reactions after a trauma. But when symptoms last more than 3 months and they're not getting better, it's time to get help. Meet Sam. He recently returned from serving in Iraq. For many people, being in a crowded place like a baseball stadium or busy grocery store feels comfortable, but not for Sam. What should be a nice night out, taking his wife Tara to a restaurant, isn't fun for him anymore. He can only handle it if he sits with his back to the wall where he has a good view of the exits, and even then, he's too on edge to really enjoy it. At home, things aren't the way they used to be either. His sleep is restless at best, and some nights Tara isn't sure if Sam comes to bed at all. Sam seems to have a short fuse these days, and sometimes he snaps at Tara over tiny misunderstandings. What he and Tara never talk about is the trauma he experienced when he was deployed. He's never mentioned the guilt, the weight he carries around, wishing he could have done more to prevent what happened. Instead, he's turned inward, pulling away from family and friends. Tara tried to give him some space, but after months passing without change, she really started to worry. She was the one to finally say what they were both thinking. It's time to get help. That's when Sam finally decided to take action. He reached out to a doctor who told him about PTSD, or post-traumatic stress disorder. Sam's symptoms were getting in the way of enjoying his life. Re-experiencing, hyperarousal, feeling worse about yourself or the world, and avoidance are the 4 types of symptoms people with PTSD have. Sam's doctor explained each. The first is reliving the event, or re-experiencing. This is often an unwanted memory or even a flashback where you feel like you're right back in the situation again. Seeing, hearing, or even smelling something that reminds you of the trauma can trigger these. Nightmares where you relive parts of the event in your sleep are common too. The second is avoidance. Staying away from situations that remind you of the trauma. That's why Sam tries to avoid thinking about painful memories altogether. He pours himself into his work or uses alcohol to keep his mind from going back to the trauma. The third is feeling worse about yourself or the world since the trauma. You might feel overwhelming guilt like Sam or not trust anyone. You just might not be able to feel happy, even when you are around people you love. The fourth type of symptom is sudden rushes of anger, irritability, feeling jittery, always on alert, always on the lookout for danger. This is called hyperarousal, and loud noises or a driver cutting in front of you can be all it takes to set you off. If you recognize any of these symptoms of PTSD in yourself or someone you love, don't wait. See your doctor to find out if it could be PTSD. Just like Sam and Tara found, there is hope. You don't have to live with the symptoms of PTSD forever. Effective treatments are available. To learn more about PTSD or how to get help, visit the National Center for PTSD website at www.ptsd.va.gov.
All right, so what assessment concerns are specific to PTSD? Sorry. All right, so when you're actually doing your assessment, some differential diagnoses to consider when assessing for PTSD, both in children and adults, include acute stress disorders. So acute stress disorder actually resolves within 4 weeks. Adjustment disorder with anxiety, in which the number of symptoms is not sufficient for PTSD. So perhaps out of the 4 that were brought up today in the previous video, perhaps they just, they're not having all of the symptoms. So in that case, you would diagnose them with adjustment disorder. Psychotic disorders, in which the illusions, hallucinations, and other disturbances are unrelated to exposure to an extreme stressor. So when psychotic symptoms accompany PTSD, however, the disorder can be characterized as severe. Bereavement, which includes the death of a loved one and is characterized by negative feelings and recollections of the loved one. And then other diagnoses to consider include mood disorders or other anxiety disorders if the trauma does not precede the PTSD symptoms. All right, so now we're going to watch a video on assessment for PTSD.
Since the accident, I'm just not myself.
What happened?
I was rounding a curve in the road at night, and then someone was driving on the wrong side coming towards me. They were in my lane.
Was there a serious accident?
He swerved and went off the road. The other driver never even stopped to help. The car went off the road and into the woods. I don't know how I didn't hit a tree head on. The car was totaled, but it just kind of went through thick bushes and finally stopped in a swampy marsh area. It was so dark. No one knew I was there. I was alone and the water came in.
Were you injured?
Not bad. I had some neck issues and some bruises. No one can believe I didn't die, though. It was a miracle.
Well, I'm relieved to hear there was no physical trauma. That was very serious, at least.
Thank you.
So, did you want to come in today, or was it your husband's suggestion?
It was a combination of both. We discussed it and thought it would be a good step to take.
Why have you not been yourself since the accident?
I have this inability to sleep lately. And I was in the car coming back from dinner and I started freaking out. We were having dinner, everything was fine. And I started having difficulty breathing and all that in the car.
What happened next?
Oh, my husband started freaking out as well. He thought something was seriously wrong, so he pulled over to the side of the road. I vomited. Then another driver stopped. Another car pulled over, and the man thought something was seriously wrong, and it was just so...
So you felt embarrassed?
I just hate feeling so helpless.
What was it that panicked you?
The light from the opposing car, the way it came at me. The road sloped up and then turned, so the opposing car came suddenly around the bend and the lights came right into the windshield.
Did the lights from the car the other night remind you of the accident?
Yes, I think so. It just took me back there. I started to feel everything and see it all over again.
Did the lights from the other night remind you of the accident?
Yes, usually most days.
Do you have any reoccurring dreams about that incident? Did that door slamming frighten you? say loud noises?
Yes.
So what does it bring to mind?
I don't know, it just makes me jump. I've never had that problem before.
And have you resumed driving?
I was too afraid to at first, but I have to with my job. I got a new car. I still can't drive at night. I only went out once.
And what was that like for you?
Terrifying. I had to go home. I was going out to get dinner, and I just decided to call in a pizza instead.
What terrified you?
Being alone?
So you don't like being alone? Did the lights frighten you as well?
It wasn't just the lights.
What else?
This will sound silly.
I'm sure it won't. These things are much more common than you would ever know.
It was a song.
What song?
It was I Want to Hold Your Hand, ironically enough. I could have used his hand.
What about the song started to make you panic?
It was playing when it happened.
The accident? I realize that you must have a strong relationship with him because it's you and him that came in today. But have there recently been any difficulties between the two of you?
I get mad at him. He doesn't understand what I feel like. He says I've been cold and distant and pretty irrational.
How would you be acting irrationally towards him?
I get frightened easily. And I just quickly decide not to go out for dinner. Or some days I just feel like I can't go in the car, so he drives me to work, or I stay home. I yell at him for being mean.
Has anything else occurred that allowed these feelings to happen outside of a car?
Yeah. Again, it's bizarre and I don't understand it. The smell of eucalyptus.
Eucalyptus?
It was a bunch of eucalyptus trees I almost hit. They smelled so strong on a crisp night. I just remember opening the door. And that smell. My husband brought some logs in for a fire.
Same thing?
Yes. I had to lay down. I was crying. I got so scared.
Could you sleep?
All right, so that was an example of a client who came in for an evaluation for PTSD. So if you have any questions about the video or the vignette or have any comments, I would love to hear them. And we can talk a little bit more at the end of the actual online module about things that you can do for the assignment and communicating to me maybe some feedback you took away from the actual interview things that you may have done differently, or things that you thought were done well. All right, so let's now go, since you've seen two different videos now. So you've seen something on what actually is PTSD. You've seen a vignette of somebody being assessed in an outpatient setting for PTSD. And now we're going to talk about the path to recovery. So what happens after?
As a busy clinician, you'll likely see patients who can't sleep or feel irritable. PTSD is a common source of these symptoms, not just among veterans, but for anyone who experienced trauma. And 60% of Americans experience trauma in their lifetime. So it's worthwhile to administer a primary care PTSD screen to identify if PTSD could be the underlying problem. It's only a few items, and it's a free download from the National Center for PTSD website. If your patient does have PTSD, let's get you up to date understanding the best treatments. For PTSD, you have evidence-based options. PTSD symptoms can be treated effectively with SSRIs and SNRIs, like sertraline, paroxetine, or venlafaxine. Two types of cognitive behavioral therapy, CBT, teach lifelong tools with lasting results, even after a short course of therapy. Cognitive processing therapy, CPT, and prolonged exposure, PE. Another psychotherapy is also effective, EMDR, eye movement desensitization and reprocessing. A huge advantage of psychotherapies is that there are no unpleasant side effects or possible medication interactions. Plus, they're more effective for treating PTSD than medications. Sometimes patients with PTSD just want to work on specific symptoms. For insomnia, effective medications include a trial of low-dose trazodone, amitriptyline, mirtazapine, hydroxyzine, or low-dose doxepin. For trauma-related nightmares, prazosin may help. Consider referral for CBTI. Short for Cognitive Behavioral Therapy for Insomnia, it's a highly effective psychotherapy that can significantly improve sleep in relatively few sessions. It's not always readily available, but worth seeking out for patients. For anxiety, treatments for PTSD we've discussed, like CBT and antidepressants, can help. The patient might be experiencing hyperarousal, part of their PTSD, rather than general anxiety or worry. Here's some news that might surprise you. Evidence shows benzodiazepines won't work for PTSD and may interfere with CBT. Atypical antipsychotics are not effective for PTSD either and carry metabolic side effects. Help your patients stop this cycle of medications that don't work. We know, my patients are on them, they really think they're helping, and you want to take them away? Consider this. These medications may seem like an easy fix for insomnia or anxiety, but why risk creating a problem down the road when there are more effective treatments? Patients with PTSD can recover. Encouraging the most effective treatments gives your patients the best chance to get better. For more information or to download PTSD screening and assessment tools, visit the National Center for PTSD website, www.ptsd.va.gov. You can also find clinical practice guidelines for PTSD treatment and recommendations regarding medication changes, including our clinician's guide to medications for PTSD. If you are a VA provider with questions about PTSD, call our consultation line, 1-866-948-7880, or email us at ptsdconsult@va.gov. And if you're a patient watching this, please talk to your provider.
All right, so now you have some information about what PTSD is, how to assess for it, what an assessment looks like, what are the effective treatments that are available, and I think that's about it. So as far as PTSD, it's very treatable. I definitely recommend, just like it was said in the video, CBT, So if you have any questions about treatment, we can talk about that in length at our next class session, or you can leave your questions. If I didn't answer any questions that you have specific to PTSD, the assessment and diagnosis. All right, so now we're going to go into reactive attachment disorder. So what is reactive attachment disorder? So, due to absence of appropriate bidirectional attachment experiences during infancy, as adults, they have a difficulty to self-soothe, self-organize, regulate affect, engage in healthy relationships. So it's really this absence of attachment experiences as during infancy while they're growing up. So this disorder is assumed to be the result of pathological parenting and often associated with developmental delays and childhood neglect. The onset of RAD is in the first years of child's life before the age of 5. RAD is distinguished from other developmental disorders by its defining feature of grossly pathogenic parental care. So implications for treatment include permanency planning for children in the foster care system. Systemic interventions in the school, community, and foster care settings should focus on educating professionals and caregivers on the need for stability and fostering of attachment experiences, in which case multisystemic therapy tends to be a evidence-based treatment for this particular population. All right, so how do you know if you actually have a child who has RAD? So it's important to know how these kids look like. So socially, they're superficially engaging and charming. They have no eye contact, poor peer relations, persistent nonsense questions or chatter, and they constantly engage in fights for power and control. So some emotional characteristics include indiscriminately affectionate, inappropriately demanding or clingy. Behaviorally, you're looking for destructive, cruel to animals, sibs, steals, lies, poor impulse control, gorging food, preoccupation with fire, blood and gore, encopresis and enuresis. And developmentally, lacks cause and effect kind of thinking. Lacks a conscience, so they might do things or say things and not really feel any remorse or any empathy when they do them. And oftentimes you'll see some abnormal speech patterns. All right, so now we actually have a 2-part series of an HBO documentary of a child who actually has reactive attachment disorder. So we'll go into what this is like, not only for the child, but also for the parents as well. I should have probably said this is an older video, so bear with us.
Are people afraid of you, Beth? Who's afraid of you, Beth?
John.
Your brother. And what is your brother? Why is your brother afraid of you?
Because I hurt him so much.
Okay. And what at nighttime? What do your parents do to your door?
Lock it shut.
Why do they lock it shut?
Because they don't want me to hurt John.
Right. And they're kind of afraid of hurting John? Of you hurting John? Okay. Are they afraid that you might hurt them?
Yep.
Would you, Beth? When would you do it?
Nighttime.
Okay. Why would you do nighttime?
Because I don't like them seeing me do it. But they can feel me do it.
And what would you do to him, Beth?
Stab them.
Okay. What would you stab him with?
A knife.
The program you are about to see was compiled from the actual therapy tapes of Dr. Ken McGidd, a clinical psychologist specializing in the treatment of severely abused children. Children so traumatized in the first years of life that they do not bond with other people. They are children who cannot love or accept love. Children without conscience who can hurt or even kill without remorse. This film shows the devastating effects of abuse on a child. It also shows that victims can be helped. It is the story of a 6.5-year-old girl named Beth.
Do you ever stick pins in people? Who?
My brother.
Okay. Do you do it a little bit or a lot?
A lot.
Okay. And what are you trying to do to your brother?
Kill him.
Why do you want your brother to die?
Because I was hurt so bad, and I don't want to be around people.
Okay. Who else would you like to stick pins into?
Mommy and Daddy.
What would you like to have happen to them?
Die.
Jesus couldn't have lived to save Israel, yet he chose to die to save the world.
Tim is the minister of a small Methodist church in the South. He and his wife Julie have been married for 12 years.
Jesus didn't say
Unable to have children of their own, they decided to adopt. In February of 1984, they received a call from the Department of Social Services telling them they had 2 children available for adoption. They were told that Beth, 19 months old, and her brother Jonathan, 7 months old, were normal and healthy.
we did not need children to make our lives complete. We felt secure in ourselves and secure in our relationship, but we wanted to share that with somebody else. And we felt like we had a lot to pass on to a child, and that was what we really wanted to do. And when the phone call came, it was like, at last it's here.
And it seemed like a miracle. It had happened so quick. We'd heard of couples having to wait 5-10 years on a child, and here we had 2 young children. It was like the answer to our dream.
Their dream became a nightmare when they realized that Beth and Jonathan had severe emotional problems.
We had the kids with us, Beth and her younger brother John, for probably a couple of months until we began to learn something about their background and their past. And when we learned it, some things seemed to fall in place about her behavior and John's behavior. From several sources, we discovered that they didn't have enough food to eat. That perhaps even Beth went all day maybe with just a box of Kick cereal. John himself was found in a bassinet with little patches of urine all over it and a dirty diaper and a couple of bottles at his feet that had curdled milk, and the back of his head was completely flat. The front of his head had bulged out, and at 7 months he couldn't raise his head, couldn't roll over. He was just had no stimulation, and we think perhaps that had happened to Beth, and it wasn't very long until she began showing some signs of perhaps even some abuse. There was a nightmare that she had, and the nightmare was about a man who was falling on her and hurting her with a part of himself.
Tell me about your birth father. What was that nightmare like?
When he touched my vaginas
Okay.
until it bled, hurt it a lot until it bled, and wouldn't feed me a lot. He'd hit on me, wouldn't be very nice to me.
How old were you?
1.
And in your nightmare, what happens?
I get real scared.
Where are you in the nightmare? What happens in the dream?
I'm in the house, upstairs,
And then what happens, Beth?
When he comes upstairs and, hurts.
How do you feel when you talk about this?
Scared.
Where's your birth father? What's he doing?
He's right there, and there's his hand. His hand's right there.
Where?
Right there. You can't hardly see it because it's green.
What's it touching?
My vaginas.
And what is your birth father doing?
Hurting it.
Your face looks sad. Can you tell me about that?
It's crying because there's spots of the tears.
Beth had endured severe neglect and abuse as a child. Her birth mother died when she was 1. Because of these early childhood experiences, Beth never developed a sense of conscience, love, or trust for anyone. The early sexual abuse by her birth father would cause her to exhibit inappropriate sexual behavior, especially toward her brother.
Does your brother have private parts?
Yeah.
Yeah? What is his private parts?
Penis and butt.
And what do you do with your brother with his private parts, Beth?
I heard it.
Tell me about it. What do you do?
Well, I pinch it. Squeeze it. Kick it.
When you do things to your brother's private parts, what does he say?
Stop.
Okay, tell me that.
Well, he says stop, but I don't stop.
Do you hurt him?
A lot.
Okay. And would you like to do that to other boys?
When I caught her with Jonathan one morning, she was molesting him. He was crying and his pants were down, and I said, Beth, what's happening? And she said, I pulled his penis and put my finger up his anus. And I said, didn't he say to stop? And she said, yeah, he did. And I said, did you? And she said, no.
Have you ever rubbed your private parts? Do you do it a lot?
A lot.
How much do you do that?
About every single day, and that's until I did it every single day until it got real bad and messed up, and I had to go to the doctor, and I did not like it.
What do you mean by real bad?
Well, it looked real raw, got all kinds of boo-boos on it, germs, a lot of stuff from my hand.
And it bled?
She started to masturbate at inappropriate times. I remember one time.
All right, so we're going to actually go into the second part of the documentary.
Basically, when we were at the hospital waiting for Tim to come out, he was there visiting, and Beth and John were in the back seat, and I turned around, and she had her legs spread and was masturbating in a public parking lot. And I had tried to explain to her numerous times before that that's private area. You don't do it in public places. And gone over that with her, and it never seemed to faze her. And
Julie, how often would your daughter masturbate?
daily, constantly.
Do you have animals, Beth?
4 of them.
Can you tell me their names?
Clyde, Shuggy, Darcy, and Annie. And Daddy said a day ago that there was a stray cat who did not have a home, so Daddy was taking care of it and took it to the vet when he had his flight to go.
And what do you do to the animals, Beth?
stick them with pins.
Do you stick them a little bit or a lot?
A lot.
What are you trying to do to the animals, Beth?
Kill them.
What do they do when you stick them with the pins?
Well, Annie cries. She's a dog.
She got baby birds down out of the nest, and we thought maybe she was just curious. So we explained that she could hurt them, put them back, and went through a whole sitting down and talking to her about the problem of it. And the next day we went out to check the baby birds, and they were on the ground dead with their necks broken.
Let's talk about what happened once when you were smaller, when you found some baby birds in a tree. What did you do then?
I took them out.
Mm-hmm. And what did Mom say to you?
That the mother will not come back if somebody touches her baby.
Mm-hmm. Are the baby birds kind of small? Can you describe them for me?
Well, they don't have their eyes open, but they can hear me, and they look up.
Are they kind of helpless? Little baby birds? Can they fly?
No.
Can they run away?
Yes.
They can? Are they easy to catch or hard to catch?
Hard.
Yeah. Well, it's hard to remember. With the baby birds, what did you do?
Took them out of the tree.
And what did you do with them?
Played around too rough. Also, when at the end, I picked it up and I thought it was Dad, and I came to say, Mommy, is this bird dead? And she said, she called Daddy and said, Tim, and Daddy came and, I think I remember that they said yes.
Mm-hmm. And so did the little baby birds die?
I don't know.
You don't remember?
I just remember that I remember that Mommy and Daddy saying the last bird we got was dead.
Mm-hmm. Do you know what Mom said to me? She said that all of them were dead. Did you squeeze them? Did Baby Beth squeeze them? You're doing a good job, honey. Go ahead and tell me what happened.
I squeezed them.
And what happened?
They died.
But this kind of aggression at our animals and even at our brother Jonathan was beginning to grow to such an excess that our life was miserable at home. John would cry in the mornings and say his stomach hurt. For the longest time, we thought maybe this child has some problem with his intestinal area, or maybe he has allergies, and so we tried to get all that checked out. Come to find out, Beth was coming out of her room and hitting him in the stomach. And so as a last resort, just to protect him, we had to tie our door shut. So I guess for the last 3 or 4 months now, we've had to tie her in at night, sort of barricade her.
The repercussions of Beth's tragic childhood led to uncontrollable rage. Despite the love and nurturing of her adoptive parents, she took this rage out on herself, on her brother, and on them. Her acts of violence became more and more cruel and frightening.
Well, I noticed several, like paring knives in the kitchen, missing. And my first thought was Beth. And I felt a little guilty about it at first. I thought, nah. But I really didn't even mention it to her. They had been gone several weeks. She was sitting at the table drawing and mentioned to me, what do those knives look like that are gone, Mom? And I said, what knives, Beth? And she said, weren't they kind of silver and about this big? And I knew then, and then this little smile that's not a sweet smile, but a malicious type of smile. And I knew then, I thought, she's got them.
Tell me about the knives. Where did you get them?
From the drawer.
And where else? Do you remember? Tell me about it.
I got them from the dishwasher.
What kind of knives?
Big sharp ones.
And what do you want to do with those knives?
Kill John and Mommy with them, and Daddy.
And when Mommy asks you about where the knives are, what do you say?
I don't know where they are.
What did you think she might do with the knives?
My first thought was Jonathan.
And the reason we thought that was that by this time, she had tried to kill John on several occasions and openly admitted that.
In the basement, she was hitting his head against a cement floor. I heard his screams and ran down and had to literally pull her hands off, and she looked wild-eyed.
Did you get real mad at him? Did you hit his head real hard? Tell me about it. How many times did you do it? A lot? What was the floor like?
Cement.
And what happened to your brother? Tell me about it.
His head hurt real bad, but his chin, he had to have stitches in it.
Could you stop? Use your words, Beth.
No.
Okay. What was your brother doing when you were doing this?
Playing with the toys.
Okay. Was he asking you to stop when you were doing it? What was he saying?
He was saying, Beth, stop.
And what did you do?
I didn't stop. I just kept on hurting him.
What were you thinking when you were doing that?
Thinking of killing him.
How did you stop? What made you stop?
When I heard Peter walking across the kitchen.
Mm-hmm.
It made me stop because I thought Mommy and Daddy would come.
Okay. Did Mommy come? What did she do?
She sent me to my room.
Okay. And what if Mom didn't stop you? What would you have done?
Kept on doing it.
And what about...
After evaluating the extent of Beth's psychological problems, Dr. McGidd felt that for the well-being of the family, Beth needed to be temporarily separated from them. In April of 1989, her parents brought her to a special home with an expert at raising children with early attachment disorders.